Welcome to another edition of Point Blank on Times Television. My name is Vana Chunga, and today I divert our attention from politics to health. It's unfortunate that many times in this country we wait for crisis to come in before we can prioritize perhaps our attention on matters of health. And today we are specifically talking about typhoid fever. How much do you know about typhoid fever as a country? Why should we be concerned about typhoid fever? Don't go away. This affects you. This affects all of us. Stay tuned. It's my pleasure today in the studio to welcome a bunch of doctors, learned doctors, but I would want you to introduce you very briefly and what is your area of specialty. I'll begin with you. Ladies first, but also nearest is dearest.
Thank you. So I'm Professor Melita Gordon. I've worked in Malawi for 19 years on problems of typhoid and salmonella. I did my PhD here and I work in Queen's Hospital as a doctor. And I do my research in the Malawi Liverpool Wellcome unit and also in the College of Medicine. The three of us have been working together on these problems for 8 or 10 years.
Welcome to the program. Thank you. And in the middle?
Thank you, sir. My name is Chisomo Msefula. I'm a senior lecturer in microbiology in the College of Medicine. But also I do research at the Malawi Liverpool Wellcome Trust. So I've been working on Salmonella, studying the diversity of the bacteria that actually causes the typhoid fever that we are discussing today.
And over there, doctor.
Thank you. I'm Tony Nyirenda. I'm an immunologist. I'm a lecturer at the College of Medicine, but I also do research. I do research on Salmonella, looking at the immunity as well as vaccines. But I also do research on malaria, looking at the immunity. I've been doing studies on Salmonella for the past 8 years.
8 years of study on this?
Yes.
Wow, we can't wait to hear. But first and foremost, why should Malawians be concerned about typhoid fever? I'll start with you, Melita. Why should we be concerned?
So I think that Malawians and other people in the region all need to be concerned about typhoid fever. We know that there was a little bit of typhoid fever in the past, all across the region, all across Eastern, Central, Southern Africa. But in the last few years, a new strain of typhoid has swept right across the whole region, through Kenya, Tanzania, Uganda, into Malawi, down through Zimbabwe, right to South Africa. And it's affected Malawi as much as anywhere else. So we know, for example, that in Queen's Hospital we've been seeing hundreds of cases each year. We know that people have lost their lives to typhoid. But we also know that there's things that we can do, things that people can do individually, things that we can do as a country, and things we can do in research to try and make this problem better.
Would you say that generally is typhoid fever given the attention that it deserves? I know we many times have talked about HIV/AIDS, we've talked about malaria, but typhoid fever, is that something that, Dr. Sefula, is that something that you would think and accept that we've given it a lot of attention, or the attention it deserves, or not? I mean, you can be very honest. This is point blank. What is your take?
My take on that is that compared to other diseases like HIV or malaria, I think we need more awareness in terms of the spread of typhoid. How does it spread? How does it transmit from one person to the next? We need to give more awareness to people in terms of getting treatment and diagnosis of the disease. So I would say with the recent outbreaks that we've seen in the papers and which people have read about, I think we need more awareness of what actually is happening in terms of the cases that we are now getting of typhoid.
Dr. Tony Nyirenda, I'm just wondering, as a scientist, most of the times you guys thrive on verified data. You want to talk about numbers. And I was just wondering to say, I mean, what are the statistics that we're talking about here? How serious, should we be worried about typhoid fever in terms of how many people are infected, or perhaps in Blantyre, maybe, what figures are we talking about?
Let me leave you to Melita, Dr. Gordon, to take that one, because she's the one who has been working on the numbers on this. I've been working on the side of the vaccine as well as the immunity.
Okay.
So she's an expert on that area. So let her take that question.
I'll come back to you, and because we'll talk a little bit more about vaccines, and so get ready. And wondering, is area of specialization immunology?
Yes.
Immunity, and we'll come back to you. Melita, what are the figures that we're talking about here?
So, at the point where we know that within Blantyre we've had an outbreak of typhoid, which has been going on for maybe 2 or 3 years, at the peak of that outbreak we were seeing many hundreds of cases each year, 500-600 cases each year. And that's now gradually beginning to come under control. It's settling down. We're still seeing hundreds of cases a year. Maybe we're seeing something like 10 or 20 cases a week in Queens. We think that over time that's going to settle down to between 5 or 10 cases, but it's not going to go away completely on its own. We still need some more action to bring it under control. And you're absolutely right. In order to understand how we could use a vaccine in future, we need to have that information about what's the burden of disease, how many cases are there. We've been very fortunate in Queens that the Wellcome Trust have funded us to do blood cultures, which is the most reliable test for typhoid. So we have accurate data to tell us that this is a real problem, and accurate data to know if the things that we're doing are working. And vaccines will be one of those very important things that we can do, but there are other things as well.
Before we can even talk about vaccines, Dr. Tony Nyirenda, I'm coming back to you. I mean, how best would you describe typhoid fever? What is it really? Because I'm sure there are other people who have heard of typhoid fever, but perhaps they can't really tell what is it. And I know there have been times when it has been there's been a mix-up between malaria, and typhoid fever. So, what is typhoid fever?
Thanks very much, Vian, for that question. So, typhoid fever is basically a disease where you have symptoms like very high fevers for some time. You tend to have abdominal pains, but also you could have problems whereby you have problems like in the liver. You can go into the bone marrow. Those are the things that you tend to get when somebody has got typhoid fever. But as you would expect, because there is a fever here in Malawi or other parts of the world, malaria is associated also with fever. That's why there's that overlap in the clinical presentation that we tend to see.
Dr. Msefula, any elements that you'd like to add in terms of how best you understand typhoid fever and how best it manifests itself symptomatically?
So as I has mentioned, that you get fevers, and it's also important that you actually get treatment quickly, because sometimes it can go on further to actually get intestinal perforations, which is a serious condition. And I would say that the manifestations may be similar to malaria, as you said, and being able to actually distinguish the two is actually important.
He's talked about perforation, happening in the bowels, and that how serious that is. I mean, at what stage does that happen? I mean,
so the typical description is that people they'll get infected with the typhoid bug. The bug will enter into the body, but it's not until after about a week that you notice the effects. And that's when people present with a high fever, and often with other symptoms, just like Tony said, maybe abdominal pain, maybe a headache, but it's not a specific syndrome. It can look a little bit like malaria, it can look a little bit even like pneumonia, it can look like many other illnesses. After that's happened, as the bug gets more and more of a hold deep in the tissues, deep in the bone marrow, it can then take a deeper hold in the gut as well. And so it's at that stage, maybe 2 weeks, maybe 3 weeks, can even be later than that. That's when you get these late complications, when the bug is really entrenched and dug into the body. And you can have these problems that Dr. Msefula referred to. You can make a hole in your bowel, or it can cause your bowel to bleed. there can be other late complications that can cause inflammation in the liver. So those tend to be quite late things, maybe even after several weeks, maybe even after the fever that started it all has begun to settle down. So, as Chisomo says, it's very important that people seek care and that we get the right diagnosis and they get the right treatment, not only so that their fever is treated, but so that they avoid these late complications which can kill people as well.
Have you dealt with cases of intestinal perforation at Queen Elizabeth Central Hospital?
Oh yes, we have certainly had an increase in numbers of cases of intestinal.
Is that curable when it reaches that stage? Is it still treatable?
It is treatable, but it requires an operation. So it's a big thing. It's a big thing. And even then the operation doesn't necessarily save someone's life, but in many people it will.
Well, there have been cases of misdiagnosis, even in the hospital. And Dr. Nsefula, I wanted to find out from you, can you clarify on that? What happens? Why do we have cases of misdiagnosis? A patient goes to the hospital a couple of times, but they're not still able to pick it up that it's typhoid fever.
So usually when you go to the hospital, you have a fever, they'll test for malaria. And if they don't find malaria, then you need to have a better test to actually find out what is in the blood that is actually causing the fevers. So the clinical diagnosis can actually give you an idea of whether someone else has got typhoid or whether they have malaria. But as Dr. Nyirenda mentioned, there can be similarities in terms of how the symptoms appear. So the tests that are there actually, which you can actually use to definitively say that someone else has got typhoid. So like the test we have at Queen's, which is called culture. You can actually do the test, but it's a test that takes about 5 days to actually confirm someone has got typhoid. But this test is it's expensive and also takes time. So it's not present in many facilities here in Malawi. It's actually just in a very, very few facilities that you can actually get this facility. We are lucky. At Queen's we have it. But on the same point of misdiagnosis, we are also improving diagnosis. We're actually working on other tests that we believe will be slightly cheaper, but also will be more sensitive than the current tests that we're actually using.
You mentioned that, Dr. Tony Nyirenda, that you have done studies both on malaria and typhoid fever. And I was just wondering, what are some of the striking similarities that you have found out from a scientific point of view between these two diseases? What are some of the things that you would say are very striking? As far as we're concerned, yes, we can talk about fever and perhaps high temperatures sometimes, but what else is there that perhaps we do not know?
So apart from the issue that Dr. Nsefula has mentioned, that we have got this clinical overlap, the things that are similar, malaria and typhoid, of course, is to a certain extent the age group that we are actually dealing with. So we're looking at children here. So in the case of malaria, we know that the huge burden of malaria is actually in under 5. But also typhoid, to a certain extent, we see it in under 5 as well. Much as we see typhoid as well in older kids as well as in adults. The same thing we also see it in the case of malaria. So those are the similarities that we see. So you could also cite issues like the diagnosis that we've talked about. There are challenges in terms of diagnosis of typhoid. The same thing also we see even in the case of malaria as well. There are challenges with diagnosis. Like the rapid test, yes, it's there, it's used, but it also has got its shortfalls as well. So challenges in the diagnostics, challenges in the facilities that we use to do the diagnosis as well. So these are the things. And just to add on what Dr. Nsefula mentioned about the blood cultures, it's important to know that apart from the blood culture that you actually do, it's also important to confirm whether the antibiotic that could be given to that patient is working or not. And these things are only done at a few health facilities in our country.
I think just to come back on the diagnostic tests, most people I'm sure in Malawi know we now have these finger prick rapid malaria tests. Those are very good tests. They're quite sensitive. They're quite specific. They're a very good quality test. They're quite reliable. The finger prick test that we have for typhoid is much less reliable. It's more difficult to interpret. It has a few false positives. It has a few false negatives. We have to interpret it in the context of knowing, does someone have malaria? What's their clinical presentation? When we examine them, what do they find? So we need much better tests for typhoid. And I think Chisomo is probably being too modest. Chisomo is, at the moment, doing a study of a completely new kind of test for typhoid that involves a PCR, which, if it is successful, will be much cheaper, it will be much quicker, and it will be much more sensitive, even the blood cultures, than we have.
Don't be modest about it. Don't be modest about it. What's the hope? What hope do we have in terms of, because it's kind of depressing to know that a lot of the hospitals that we have in Malawi, or clinics, are not in a position perhaps to be able to pick up, typhoid fever. And most of the people in this country, they live outside, the cities, outside Queen Elizabeth Central Hospital.
Yeah.
And what is being done, to give a remedy, to that situation that we're struggling with in this country? You want to clarify more on that?
So in terms of diagnosis, we've just finished one study where we designed some parameters to be able to detect typhoid in blood, and we did that locally. So our aim is to be able to, someone comes to the hospital, we are able to detect the salmonella the same day, and also that we are able to have a test that is more sensitive. Mm-hmm. So the test we have now is the test that we are working on at the moment is potentially twice as sensitive as the one that we are using at the moment. So our aim is to be able to have a test that is more sensitive, but also provide the results quickly. So there is that one, and then we have just started running another test. Both tests are actually based on, not to get too technical, but they're actually based on the DNA of the bacteria, detecting it, identifying it in the blood of the patient. So our hope is that this test, which is called a PCR, as you mentioned, we are hoping that once we've done the evaluation and our results are effective as we hope, that we'll be able to have this test in specific hospitals where people can actually go and have a definitive test instead of just guessing, where they just check you don't have malaria and then they just give you antibiotics. Mm-hmm. So our hope is that we'll have, once the evaluation is done, a test that is effective, that is quicker, but also a test that is more sensitive. And then we could have these in set facilities within the country, and people can actually access the effective diagnosis.
You just spoke as a microbiologist right there. Well, maybe we need to talk a little bit more about what causes, typhoid fever and how best can we prevent it. And we may also talk a little bit more even about the vaccine. But why don't we take a short break, and after we come back, we'll take it up from where we stopped. Welcome back. You're watching Point Blank on Times Television. My name is Chunga, and today I'm joined by 3 researchers, scientists, doctors, talking about typhoid fever. As I mentioned in my introduction of this program, many are the times in this country where we wait for crisis to do something about some of these diseases. Yes, we've talked about malaria. Yes, we've talked about HIV/AIDS. Yes, we've talked about cancer. But do you know that we also need to be aware that there is typhoid fever in this country? Stay tuned. Don't go away. So, welcome back. And we begin with you, Dr. Chisomo Nsefula, a microbiologist. Tell us a little bit about this animal.
So, as you've mentioned, I'm a microbiologist, so I study things that you can't actually see with your own eyes. You actually need to have a microscope to see them, but they're there. So one of them is this bacteria that causes typhoid. We call it Salmonella. So it's a tiny organism. We are able to grow it in the lab. We can actually grow it from the blood of someone else who is actually sick, which means it's in the blood. and that's why people get the fevers. So it's a bacteria that actually can transmit from one person to another person. It doesn't have to go through other animals. So this is a bacteria that, if we are actually being effective in our control, because it's just between humans in terms of transmission, we can actually completely stop it. It's unlike other bacteria that maybe may go through chickens, some may go through other domesticated animals that we keep at home. So this is a bacteria that transmits human to human, and and we know that at the moment it's resistant to a number of antibiotics, which is a big problem. And that's why we actually need to find ways of actually stopping the transmission of the disease. Yes.
And how is the contamination process?
So, as Chisomo says, it's a bacterium that only infects humans, and after you've been infected, it's then excreted in the feces. So it passes from one person to the other because there's contamination from the feces, either in the household or in the environment around the household or in the area where people are growing vegetables, for example. So that's how it spreads, is because the feces are not well dealt with. Maybe the latrine overflows, there aren't proper sewers. Another way that it can be transmitted is if human feces are used to fertilize fields before they've been properly composted and before it's safe. So those are the ways that it's transmitted inside the household and then also around a neighborhood. And it can spread from person to person that way.
Well, and is there any addition you would like to make, Dr. Tony Nyirenda, before I move on perhaps to another question?
No addition. I think we have explained that quite very well.
Oh, quite well. Okay, now, in terms of prevention, you have talked about your interest of research and work in vaccines. We also are going to come back with you, because you deal with patients perhaps on a daily basis, how best can we prevent this? But let's digress a little bit and talk about the vaccines. What's the history of vaccination on typhoid fever?
Okay. So typhoid is a disease that has been there for so many years, over 100 years. And actually the first vaccine that was made for typhoid was actually made in 1950s. But it has got, shortfalls because in terms of the protection that it does induce is not up to 100%. So only about 50% or so can actually be protected. And even in terms of how long that protection would last is also limited. So not more than 2 years or so. So that's not good enough. So the position is that it's better, to have good vaccines that can actually be used to prevent these diseases. But I should also be quick to mention that it's not just vaccines when it comes to prevention of typhoid. They have clearly mentioned that, Salmonella typhoid is actually, spread through fecal-oral route because you have touched things that are actually contaminated by the feces. So there's an issue of sanitation that you have to deal with. Okay, if you deal with the issues of sanitation and food hygiene, to a certain extent, you have, controlled or prevented typhoid. And then there's the issue of vaccination, which we are talking about, and we can expand on that. And there's also the issue of treatment. So people have to be treated appropriately. So it's possible that others could have an acute infection, so a latent infection, but others could also have a chronic infection. So they will be shedding these salmonellas for a very long period of time. So all these individuals, they have to be treated, be it latent infection or chronic infection. So treatment is important, vaccination is important, and also sanitation and food hygiene issues.
At what moment do you do vaccination?
So the issue of vaccination, in the first place, we need to say, do we have the appropriate vaccine? Okay. Do we have sufficient numbers that necessitate, a vaccination program. Okay, like in the case of Malawi here, where we have got outbreaks, really we actually need, a vaccine. But you can't just lash into, administering a vaccine without doing, proper, studies. So there are things that you need to look into. Things like to say, okay, which age group, for instance, is most affected? Is it children? Is it adults? Okay. And then we have to target, that particular age group. At the same time, we need to look at issues of the immune response that, is being induced by that particular vaccine. So there are all these issues that you need to take into account. But first and foremost, when you see that there are sufficient numbers that necessitate a vaccination program, that's where you actually need that.
Now, I've heard at times that with vaccination, you actually literally, take a living organism and, inject it into somebody's body. Mm-hmm. Is this the kind of vaccine that we're talking about?
So yes. So it depends on the type of vaccine that the older, typhoid vaccines that I've talked about that have got limitations. Those ones are the way you're actually taking it, through the oral. So it's the oral route. But the VI, the VI, which is the newer vaccine, you have to actually inject it on the skin. Yeah.
Now, Tony talked about the old vaccines. I think the thing that's very exciting now is that there's a new vaccine. It's called a conjugate vaccine, and it's a completely new way of designing vaccines. Mm-hmm. So, like you said, old vaccines were maybe a sort of disabled, weakened bug that would get injected. Mm-hmm. That's an okay vaccine. There are old vaccines that are based around sugars, but they're not very effective in very young children, and they don't last for very long. But the new vaccine is called a conjugate vaccine, and it's a protein linked to a sugar, and that makes it 97% effective. It means that you can give it to very young children, and it means that it lasts a long time. Uh-huh. So we're in a very exciting new period now because these new vaccines are in the process of being approved by WHO for governments to then consider using them. Uh-huh. And we would like that these new conjugate typhoid vaccines can be introduced in Malawi as soon as possible. And Malawi is one place that may be able to be the first place in Africa to have these vaccines introduced. Uh-huh. So that's what we're really all working towards, to get away from the bad old days of these rather weak vaccines in the past that were never really worth using, to the current new vaccines, which are very exciting.
I've heard a lot of talk about children here, perhaps under fives. Are adults immune to this?
No, they're not. So all age groups do get affected with typhoid. So regardless of whether you have a stronger immune system or you have a weaker immune system, you do get affected. So everyone else needs to have personal responsibility to actually protect themselves, protect their neighbors, protect everyone, basically. In the country. Yes.
And talking about immunology, which is your area of work, Dr. Tony Nyirenda, yes. People who have HIV/AIDS, people who may have low immunity, how susceptible are they, to typhoid fever?
They are susceptible as equally as everyone else, but in terms of their susceptibility, it's not that unique compared to other bugs. Okay, we could give an example of, let's say, pneumonia. Okay, you will see that the HIV-infected individuals, they tend probably to develop pneumonia or TB, which is not necessarily the case in the case of typhoid. So yes, HIV-infected individuals could be infected, but it's not a very important factor in the case of typhoid.
I'll come back to you and now begin to unravel the journey of prevention of typhoid fever, to say, what can we do as a government, as hospitals, as a nation, as Malawians, as families, at an individual level? What should we do to win this battle against typhoid fever?
So I like the way you frame that question, because I think that we can work from individual people and their households through their neighbourhoods, right up to the level of researchers like us, and then to what government can do. So inside the household, washing hands before you prepare food, washing hands before you eat. That can help protect everybody in your family and protect yourself. Within the household, having a proper latrine that doesn't flood, that you are not defecating in the open, not just defecating in the fields, not using feces to compost unless it's been composted properly for a long period of time and it's safe. These things inside our household are important. Also within the neighbourhood, if water supply is safe, if the pipes aren't leaking, then that is a very important way to keep the water supply clean, and that will prevent typhoid. So there's many things inside the house and inside the neighbourhood. As researchers, we very much feel we have a responsibility to help with things that will help the health system, like the diagnosis that Chisomo is working on. That's very much our responsibility. We also need, as Tony says, there's a lot of research around the vaccine. When this exciting new vaccine comes, how will we use it? Will it be in very young children? Will it be in children around 9 months? Will it be in school-age children? Will we need to vaccinate adults as well? This is something that we need to decide based on the information that we get from our research, and we can help the Ministry of Health to decide that. So that's a big responsibility on us as researchers. Now, as far as the government goes, I think the government obviously also has big responsibilities. The ideal scenario would be that every house, for example, in Blantyre or Lilongwe, would have perfect sanitation. They would all have flush toilets and sewers. We all know that that will take many, many generations to achieve. But there are other things that the government is already doing around some of the outbreaks that we've seen in Malosa and Zalewa. They've detected cases, they've chlorinated the water, they've treated cases, and they've made a very effective response. But the bigger thing that we will be able to implement, we hope, is vaccination. And I think communities inside Malawi also are stepping up to the challenge of engaging with the research that we are doing to be able to bring these vaccines in. So, for example, at the moment we have a large study in Indirandi in Blantyre called the Strata study. The authorities in Indirandi have approved and encouraged us to do this study, and nearly everybody in Indirandi has engaged with this study. They've been censused and counted. We're measuring how typhoid behaves in Indirandi, and that whole community is taking a big responsibility to help to introduce vaccines to Malawi. And with the information we get from that study, we will then be able to go to government and say, look, this is the information you need to be able to use this new vaccine. I think the final thing about responsibility is to say that it even goes above the government of Malawi. So there's an organisation called Gavi, which is an international alliance to try and make sure that vaccines get used as quickly as they possibly can. And Gavi will assist the Malawi government to introduce vaccines like this if we can make a good case, if we can understand the best way to use them, and if they're cost effective. And I think that's something that all of us, from the individual household level to the community level, through the researchers, right up to Ministry of Health, can work towards that kind of intervention, which will be internationally supported.
Dr. Chisomo Msefula, in your years of microbiology and research, especially on typhoid fever, what would you say are some of the gaps that you're concerned about, where you would love, for Malawi as a country, to do better?
So in terms of the gaps that we have at the moment, I think she's mentioned of this big study happening in Derandi, the Strata study, which is basically to sort of prepare the country for the introduction of the vaccine. So we actually need to know what's the best way to actually design the program for a vaccine within the country. That's really important for the country in preparation of this WHO-approved vaccine. So that gap through this study that's happening in Durand, I think will eventually be addressed, and then that will actually help in the fight against typhoid. But the other thing that's personal to me is so in terms of the study that I'm doing, diagnosis, having an effective diagnostic tool that the labs in our country can actually use. We actually need to work hard on that and be able to develop a test that actually provides better information to the clinician who's actually treating the patient. So the good thing is that we're already working on these two areas. So I'm doing the diagnostics. She's leading this big study in Durand where they're trying to have interventions on vaccines, and also as an immunologist, he's also working on trying to study the population, study the behaviors of people, and trying to prepare for a vaccine that has been proven to be effective. So,
as poor as Malawi, thank you for your answer. But as poor as Malawi is, Dr. Nyirenda,
Yes.
how affordable will this vaccine be?
Thank you, Vayan, for that important question. So one thing that we know, and is generally acceptable for all vaccines, is that vaccines are expensive. They are very, very expensive. It takes so many, many years to generate these vaccines. And it's important, though, to appreciate that if we would have vaccines that are cheaper, then that would actually be good. So I would say that yes, the responsibility falls on the government, but there are channels that the government can actually exploit, like the Gavi that Dr. Merita Gordon did mention earlier on, that the government can be able to apply for funding so that vaccines can be made available to the Malawian population. So I don't think that the Malawi government on its own can be able to lower this, because the burden of diseases here in Malawi, there are just so many. And but there are opportunities, to tap some resources from organizations like Gavi. Yep.
I think the other thing to say is that we work with a group in Princeton in the USA who have this big interest in what are vaccines good value for money. Can the government afford them in terms of how much it costs to save people's lives by introducing vaccines? And it's very clear from the analyses that they've done, and that even these new typhoid vaccines are very cost effective. So in the long run, for the Malawi government, it will be cheaper to introduce the vaccine than it will be to continue to have many, many cases of typhoid, to have to pay for the diagnosis, to have to pay for the time in hospital, to have to pay for the treatment they need, for the amount of money that each household loses when someone's sick and they go into hospital and then they can't earn money. All of these things add up, and it means that in the long run, although vaccines do cost money, it's actually cheaper to have the vaccine and prevent the disease.
Dr. Chisomo Msefula, what are your last words as far as typhoid fever is concerned? If people are just switching on the television now and watching you speak or watching this program as we wind up, what is one thing that perhaps you'd like to emphasize or bring out for people's attention?
I would say for everyone watching to be aware, and also to let their neighbors know that there are actually epidemics happening. It's a reality. I mean, we've had a number of reports. So I would actually plead with everyone to actually follow the measures of prevention and control. So making sure that you wash your hands when you get out of the toilet, making sure that you are preparing food in clean surroundings, making sure that for those who are using this latrine manure as fertilizer in the fields, make sure that they follow the procedures necessary to make sure that they're actually well composted, so that you're not actually transmitting disease in trying to fertilize your fields. So prevention and control are actually key for us to stop these epidemics that seem to pop up in the and being reported in the papers.
So in addition to what Dr. Msefula has already said, we talked about the 3 key ways how to prevent typhoid, which is treatment, vaccination, but also good hygiene and sanitation. So on the part of treatment, Malawians out there have got the responsibility, and that responsibility is whenever they notice that they've got fever for some days, it's better for them to seek care. This is health care. They should go to a health facility so that they could be screened properly, and if it's confirmed, they should be treated appropriately. That way, then we're going to prevent new cases. Otherwise, if they are sick and they're just living at home, it's no good, because it will keep spreading, and we want to stop the spreading of typhoid.
What treatment do you give to someone who has typhoid fever?
So the treatment was with antibiotics. In the past, we used to be able to use the very common antibiotics, what we would call the first line. This new strain that we talked about at the beginning, that has come from Asia and is spread right across Africa, is resistant to those. So now we've already had to step up and use second line antibiotics. Now the government has made those available. They are there. If people have typhoid, the ones in the health centres and the hospitals, they know which antibiotic to use. But if we use it badly, then we'll become resistant to that as well. And after that, we only really have one antibiotic left.
You've said something important. How do you use it badly? I mean, what's a bad way of using an antibiotic?
A bad way of using an antibiotic is using it for the wrong indication, using it when you don't really need it, using the wrong antibiotic for the wrong illness. Because then what happens is the bugs get a little bit exposed, but they survive and they come back stronger than ever. So, as Tony has said, going to your health facility, getting the right diagnosis so you get the right treatment, means that these antibiotics will remain effective and we'll be able to use them in the health system in Malawi.
Dr. Melita Gordon, what are your last words?
My last words, I think what Chisomo and Tony have said are very, very important about sanitation, about people's individual responsibility around sanitation, and about going to the hospital and getting treated. My last words would be to say how important I think and how exciting I think the research that's going on in Malawi is. We've talked about these trials. They're not being done in Kenya or Uganda or South Africa. They're being done here in Malawi. Malawi is very well known for being a leader in understanding salmonella and preventing salmonella. So I would really commend the members of the population, the people who come to hospital, who engage with our research studies, who join in with our research studies. They're being partners with us and partners with the government for Malawi to lead the world and to lead Africa in controlling salmonella and typhoid fever. And I would like really that people recognise their own contribution and their own responsibilities, and what an important leader Malawi is right across Africa in preventing typhoid.
Well, it has been a pleasure to have you in the program. And on that note, we have also come to the close of our today's edition of Point Blank on Times Television. A sick nation cannot progress. Your health matters, and it starts now. You have a personal responsibility, and as a nation, we can do better. My name is Vana Chunga. Until next week, when I'll come again with another edition of the program, it's God bless and bye-bye.